Hi everyone, my name is Joe Featherall, and today we're going to be going over a topic guided by a specific clinical question of is there a superior technique in distal biceps tendon repair? This presentation was originally prepared for a sports medicine conference during my sub-internship in orthopedic surgery at NYU Langone Orthopedic Hospital. We're going to be taking a little bit of a different approach to this topic, and hopefully it tells a bit of a story, which makes it enjoyable, and it conveys a lot of important content about how this technique has developed over the years. So we're going to start off on a historical note with Dr. Robert Dobby's case series that was presented in 1941 about how the first scientific approach to this procedure came about. We'll talk about the developments in the 1960s, particularly the Boyd-Anderson approach, or the two-incision or posterior approach, and how this changed some of the thinking about this procedure. We'll also look at some biomechanical and anatomic studies that are a bit more recent. And then, without getting too deep into the basic biology to make it dry, we're going to look at some of the bone and tendon healing principles, and then finally end on a summary and some discussion points. So Robert Dobby was a surgeon in Buffalo, New York, and in the early 1940s, he wrote a letter to the American Orthopedic Association asking its members to send him descriptions of their repairs of avulsed distal biceps tendons. And he compiled these into a case series which started to facilitate our scientific knowledge of this procedure. And I included this just out of curiosity and interest. As you can see here in this approach that was used in 1898, it was a direct suture to the bicipital tuberosity, which is the same type of procedure that we do today, which is quite amazing. At the time, though, there were a lot of different approaches and tremendous variability. For example, the catgut woven into tendon end approximated tendon to radial tubercle, brought suture ends through counterincision on the dorsum of the forearm, and tied them over gauze. So it was sort of an X-fix type approach to repairing this tendon. A bit more crude than the techniques that we use today. Dobby himself also had a technique that he described in his case series, and interestingly, Dobby describes his first attempt at this procedure and says that as he enters the antecubital fossa and divides between pronator teres and the brachioradialis, he was astounded at the number of vital structures in this region. And this motivated him, instead of reattaching to the biceps tuberosity, to take the tendon ends and weave them into the brachialis muscle, and then oversew with catgut and silk sutures. In doing this, Dobby repaired the biceps tendon into a flexion-only mode and did not preserve the supination moment that the tendon natively has. In his case series, he found that about 80% of the submitted approaches to this repair were attaching the tendon to the radius. About 20% attached the tendon to other sites, himself included. There was one case of myositis ossificans, also known as heterotopic ossification, one radial nerve palsy with recovery, and one without recovery. This totaled a 4.8% rate of radial nerve injury in the radial attachment group, sort of an interesting statistic to hang on to. And because of this, Dobby argued for non-anatomic reattachment of the tendon, given these radial nerve injury complications and what he thought were good to excellent functional outcomes with non-anatomic attachment. In the 1960s, there was some press in the literature for non-operative management. Particularly Carroll and Hamilton in 1967 published a case series and demonstrated that 10 out of 10 patients managed non-operatively returned to work in an average of about 4 weeks, with minimal apparent loss of supination strength. However, at the same time, other authors were describing varied results. So Friedman described that there was variability in patient ability to compensate for the injury. And then Marin in 1960 described the motion of compensation being the abduction of the shoulder, followed by adduction of the arm while externally rotating the forearm. And although you can't see me doing that motion right now, basically the injured patient would use rotation of the shoulder in the coronal plane to compensate for the lack of supination motion. And although there was mixed results with the non-operative management, Mori in 1985 put together a landmark study that compared conservative management to acute tendon repair. And in his case series, he used Cybex testing to compare those acutely repaired biceps tendons, those chronically repaired biceps tendons, and those managed non-operatively. And the acute repairs versus the non-operative repairs did much better. The non-operative group showing 40% loss of supination strength, 75% loss of supination endurance, 30% loss of flexion strength, and 30% loss of flexion endurance. And this sort of solidified the distal biceps tendon repair as sort of a desired approach. In 1961, Boyd and Anderson published 3 cases of a 2-incision approach that theoretically limited radial nerve injury while addressing this supination strength. And what they did is they used an auxiliary or secondary incision in between anconeus and the border of the ulna to directly access the radial tubercle posteriorly, and thereby allowed reattachment directly to the tubercle without vigorous retraction on the lateral antebrachial cutaneous or posterior interosseous nerves. However, in the years following this approach, as it became popularized, some authors noticed that it had a tendency towards heterotopic ossification. And in response to this, Mori and colleagues suggested a muscle splitting approach through the extensor mass. So as you can see here, classically in between EDC and EDU, accessing their radial tubercle, again, stopping the violation of the periosteum of the ulna, which was thought to be implicated in the heterotopic ossification. This then became the gold standard of repair. Fast forwarding a bit, Gruel et al. In 2012, in a relatively elegant randomized controlled clinical trial, showed no difference in the anterior versus posterior approach when using indomethacin 2.5 milligram 3 times daily prophylaxis. And they had 2 groups. The anterior group, 1 out of 47 developed mild heterotopic ossification, and in the posterior group, 1 out of 43 developed mild heterotopic ossification, essentially showing no statistically significant difference. Further, in the early and late 2000s, there were a number of anatomic and biomechanical studies that were conducted to better elucidate the functioning of both the short and long head biceps tendons. As you can see here in this cadaver study, the short head attaches somewhat distally on the radial tubercle, and the long head here attaches somewhat proximally. Because the short head attaches distally, it has a longer moment arm from the instantaneous center of rotation of flexion, and thus generates about 15% more of the flexion moment. The long head, because of its shorter moment arm in flexion, and also because of its relationship to the protuberance of the biceps tuberosity throughout the range of flexion and supination, generates greater supination torque. As we can see in this MRI cross-section here, there is some interesting detailed anatomy of the radial tuberosity. So as you can see here, the biceps tendon attaches, or its center of its footprint is about 24 degrees from the apex of the radial tuberosity, and you can see the relationship with the prominence of the tubercle, or the biceps protuberance. So you can see that as the radius were to rotate in this direction, the protuberance would increase again the radius of the biceps tendon from the instantaneous center of rotation, increasing the torque via its cam-like properties. So this has led different authors to try to recreate this complex and dynamic anatomy of the tendon and its relationship to the bony anatomy of the radius via anatomic repair. And here you can see Schmidt's method for doing so, drilling 2 holes for cortical buttons on the posterior aspect of the radius. The tendon is then drawn down around the radius, or wrapped around it, and drawn into the, or drawn against the cortex, I should say, with the cortical buttons, then creating a anatomic repair with 2 attachment sites of the 2 heads of the tendons. And as you can see here, it preserves the radius or moment arm of the biceps tendon and how the tendon wraps around the radius, generating torque throughout the entire range of supination movement. This brings into question a little bit about the healing. As we could see in Schmidt's repair, it was to cortical bone, and authors advocate for anatomic repair to cortical bone rather than burring away or cutting a trough into the tubercle as it decreases the radius and therefore the supination torque. However, the recent literature does not support the traditional notion that cancellous healing to tendon is better than cortical healing to tendon. St. Pierre et al. In 1995 used a goat rotator cuff repair model and found very similar histology, and also noted that failure was almost universally an avulsion fragment in both cortical and cancellous healing, implicating or indicating that the healing of the tendon to bone was stronger than the bone around it and was not a failure mode or a reasonable failure mode in either of those healing modalities. Soda et al., a Japanese group in 2003, used a rabbit MCL reconstruction model and again found no difference in load to failure and very similar histological outcomes. And you can see those here. On this side, or on the left side, we have the cortical bone to tendon interface at 4 weeks. And you can see these Sharpie-like collagen fibers leading into the region of cortical bone, as you can see here. So this would be cortical or lamellar bone. This would be tendon. And these fibers extend across that interface, very similar to what we'd expect with Sharpie fibers. And then on the right-hand side, we can see the same thing in a cancellous tendon interface with these fibers continuing into the osteoid or bone material in this region here. So this would be bone and this is tendon. In summary, PI and injury has been plaguing this procedure since it was initially described by Dobby and even prior to that. The current rate of about 3.2% in the anterior approach, and in this particular report, none of those nerve palsies were permanent. All of them resolved within a few months. However, it is not that different from Dobby's initial description of about 4.8%. So even though our technology has progressed tremendously, the anatomy hasn't changed, and the rates of injury remain similar. HO formation has largely been mitigated by indomethacin prophylaxis, and again, the modified 2-incision approach, staying away from the ulnar periosteum. Some recent anatomic and biomechanical studies have provided data for optimal repair positioning. And when it comes down to supination strength, flexion strength, and endurance in both of those motion modalities, anatomic repair is similar due to the nuance of the insertion of the biceps tendons. Animal models have also elucidated the bone-to-tendon healing principles that cortical and cancellous healing seem to be equivalent both histologically and in terms of strength to failure. This also raises some questions for the future, is that are there any methods that may offer improvement? Some authors advocate for arthroscopic techniques, particularly hooded arthroscopes, that allow for minimizing the retraction of vital structures in the antecubital fossa. Some authors have described use of flexible instrumentation that allows for more anatomic repair with less vigorous retraction. And there's even some techniques out there that I thought were quite elegant, using shuttle sutures to attach the tendon to the posterior aspect of the tuberosity, thereby using an anterior incision, but attaching the tendon posteriorly and giving a more anatomic repair with a simpler approach. So with that, I hope that this presentation was both a little bit of an enjoyable story of the history of this procedure, and also went over some of the critical principles, both anatomically, biomechanically, and with regards to the biology that really well describe our knowledge of this repair technique. Thank you.